Hi everyone, my name is Natalie Morgan. I am the Pharmacy Oncology resident here at Monument Health Cancer Institute, and my clinical pearl for this month is looking at understanding paraneoplastic syndromes. Objectives for this presentation include describing the overall pathophysiology of paraneoplastic syndromes, and then listing some of the common malignancies that are associated with development of paraneoplastic syndromes, talk about different categories and types of syndromes, and then finally talk about standard treatment options for paraneoplastic syndrome. I wanted to start the presentation by talking about a case study that I found very interesting from the New England Journal of Medicine. This was a 27-year-old Japanese female. She presented to the ER for a 5-day history of quote, strange behavior. She'd been experiencing nausea and palpitations and then had developed short-term memory loss as well as anxiety. And then her symptoms had worsened to include agitation as well as visual and auditory hallucinations. Vitally, she had a low-grade fever, she was tachycardic and hypertensive, and very disoriented in the emergency department. She was yelling, she was flailing her arms, and unable to follow commands. A lumbar puncture was obtained, and she was started empirically on bacterial and viral treatment for meningitis. Her urine drug screen was negative, her head CT was unremarkable, as were her other lab work. She'd immigrated from Japan 5 years ago. She'd had no recent sick contacts. She lived independently with her husband, and she was not taking any medications besides a prenatal multivitamin prior to admission. So I just wanted to keep this patient case in mind as we go through the rest of our presentation, and we'll come back to her at the end. So first off, I want to talk about, just in general, the pathophysiology and epidemiology of paraneoplastic syndromes. Paraneoplastic syndromes were actually recognized over 100 years ago, and this occurred when there were symptoms that people realized were not attributed directly to either a tumor invasion or spread or metastases. Also, symptoms that were not related to any sort of metabolic abnormalities or side effects from cancer treatment or coagulopathies. And these were initially described as paraneoplastic disorders in the 1940s. They are estimated to affect about 1 in 300 patients with cancer, so prevalence of about 8% among all malignancies. And very important to note that they may be present before cancer is diagnosed, so they may be the first precursor of an underlying malignancy. For pathophysiology of paraneoplastic syndromes, it's thought to be related to an ectopic tumor secretion of a variety of substances, including peptides, cytokines, and hormones. And this is thought to lead to an immune cross-reactivity between the tumor and normal host tissues, like we see with a lot of autoimmune disorders. So essentially, this autoimmune attack against the tumor spills over into our normal host tissue. And these antigens are released as a result of tumor cell death. And they can occur in either the central or the peripheral nervous system, as well as other body systems, including endocrine and dermatologic and hematologic. But these onconeural antigens are kind of the foundational causes of paraneoplastic syndromes. And actually, the terminology has recently been updated as of 2019 to include a broader definition with high risk and intermediate risk antibodies. And we'll talk more about those coming up, but essentially their risk is related to their association with development of cancer. This is a list of some of the most common malignancies associated with paraneoplastic syndromes. Small cell lung cancer in adults is going to be a very, very common cause of paraneoplastic syndromes, and then neuroblastoma, especially in children, is going to be a common cause. Other malignancies, you can see breast, ovarian, Hodgkin lymphoma, and thymoma. So here is a listing of the high-risk antibodies that I was talking about previously. And these are high risk because they have greater than a 70% association with malignancy. And I wanted to draw attention to two in particular. The anti-Hu or ANA1 is the anti-neuronal nuclear antibody type 1, which is especially common, and we'll see that on multiple slides. But you can see there are different phenotypes that are related to finding this antibody. And we'll talk more about sensory neuronopathy as well as GI pseudoobstruction and encephalomyelitis, but a high frequency of association with cancer at 85% and then very prevalent in small cell lung cancer. The other one I wanted to draw attention to is the anti-Yo or PCA1. This is the Purkinje cell antibody, and this is commonly associated, 90% association with cancer, but very often found in our gynecologic malignancies, so breast and ovarian cancer. So these are our intermediate risk antibodies, and they carry a 30 to 70% association with malignancy. I did want to draw our attention to the NMDAR antibody, which is associated with the anti-NMDAR encephalitis, and especially can be found in ovarian or extra-ovarian teratomas, as this may relate to our patient case that we talked about earlier at the beginning of the presentation. Next, I want to talk about diagnosis of paraneoplastic syndromes in general. So here, in terms of diagnosis of paraneoplastic syndrome, as we talked about earlier, it is important to think about other causes that may not be related to paraneoplastic syndrome, whether that's due to direct tumor spread or invasion or, side effects of chemotherapy treatments. So this scale is helpful in terms of determining if it is actually likely to be a paraneoplastic syndrome. So first off, we have our phenotypes, and I'll talk more about that coming up on the next slide, but in terms of what is the syndrome that the patient is actually presenting with. And then as we talked about earlier, we have our different antibodies and their risk level based on their frequency of association with malignancy. And then finally, we have determining if there is actually a malignancy or a tumor present. And so patients with a score of 8 or more would be considered to have definite paraneoplastic syndrome. Those between 6 and 7 have probable, and then those between 4 and 5 have possible, and those less than or equal to 3 have probably non-paraneoplastic syndrome. So these are examples of our high-risk phenotypes, meaning that there's a strong likelihood that there is an underlying paraneoplastic syndrome. These were previously called classical phenotypes, and then with the 2019 guideline change, they were broadened to be high-risk phenotypes. As you can see, a lot of them are neurological, including encephalitis, encephalomyelitis, opsoclonus, myoclonus, but then there are also others, including dermatomyositis and chronic GI pseudoobstruction, and we'll talk more about these. So what do we do when we have someone that is suspected of having a paraneoplastic syndrome or potentially has a definite paraneoplastic syndrome? First off, and the biggest priority is to determine if they do actually have an underlying malignancy. So we want to have a thorough screening involving a CT of their chest, abdomen, and pelvis, as well as a careful skin examination. Also for males, we would recommend a scrotal ultrasound to determine if there's any testicular malignancies. For female patients, mammogram as well as transvaginal ultrasound and or a pelvic MRI would be important, especially if there's a suspected ovarian teratoma or adenocarcinoma. If these initial screenings are negative, then we would recommend going on to a PET scan to determine if there are any occult malignancies. Next, I'm going to talk about treatment of paraneoplastic syndromes. So for treatment of paraneoplastic syndromes, first off, as we saw with that scale, it is important to kind of determine if this is likely due to a paraneoplastic syndrome or if it may be due to another symptom, another cause that's not related to malignancy. There definitely is an overlap with a lot of the syndromes that we're going to talk about. So that's definitely first priority. And then second is to identify if there is any underlying malignancy through careful screening and examination. If there is an underlying tumor that's found, then most importantly, we want to treat that tumor to help correct the paraneoplastic syndrome. And then generally patients are going to be initiated on immunotherapy as well, and I'll talk more about that on the next slide. Immunotherapy is a mainstay of treatment for paraneoplastic syndromes and can involve a variety of factors. We have IV corticosteroids like methylprednisolone. This is typically given as 1 gram daily for 3 to 5 days and then given weekly for up to 6 to 12 weeks. Methylprednisolone and corticosteroids in general help to inhibit the nuclear factor kappa B pathway, and this is involved particularly in the inflammatory cytokine release cascade. And by inhibiting this pathway, they help prevent aggregation of both B and T cells. Common adverse effects related to all steroids include hyperglycemia, as well as decrease in bone mineral density, avascular necrosis, and an increased risk for infection. So for patients receiving long-term corticosteroids, it is important that they have a bone density screening as well as supplementation with calcium and vitamin D, and then prophylaxis with either a proton pump inhibitor or an H2 receptor antagonist may be recommended for prevention of gastritis while they're on this extended duration of steroid therapy. IV immunoglobulin or IVIG is also recommended, again given as a daily dose for 3 to 5 days and then weekly for up to 6 to 12 weeks. IVIG directly will bind to pathogenic autoantibodies and then help inhibit the complement cascade. Some of the adverse effects with IVIG include hypercoagulability, as well as anaphylaxis, especially if the patient has an IgA deficiency, and then it can be renal toxicity as well, including acute tubular necrosis can occur. With the risk for hypercoagulability, it is important to be cautious with IVIG in patients that have a history of prior DVT or PE, and then close monitoring of renal function is recommended. Last, we have plasma exchange, which is helping to directly remove the autoantibodies as well as the cytokines. So with removal of those immune factors, there is certainly a risk for infection. And then with the central line required for administration can be a risk for pneumothorax as well. It is recommended to monitor electrolytes and fibrinogen as well during treatment. And then a lot of times patients will be started on some sort of maintenance therapy after they finish this acute phase. And often that can be either cyclophosphamide or rituximab, azathioprine or mycophenolate. These agents are particularly going to be preferred if there's a T cell response that's suspected in leading to the paraneoplastic syndrome, since these agents help to target both the B and T cell lymphocytic lineages. And then also patients often require a slow prednisone taper over, up to 12 to 16 weeks as they're being initiated on these maintenance therapies to help prevent any recurrence of the paraneoplastic syndrome. So what do we do for follow-up and monitoring? So it is important, again, as we talked about, to thoroughly screen patients that have a likely paraneoplastic syndrome for an underlying malignancy. If that initial screening is negative and they have one of the high-risk phenotypes like Lambert-Eaton syndrome or opsoclonus myoclonus, as well as the presence of those high-risk antibodies, or they have a high-risk phenotype and they have intermediate risk antibodies with patient-specific factors like older age or history of smoking, then it's recommended that they have repeat cancer screening every 4 to 6 months for 2 years. And that 2-year time frame is recommended because that's really when the vast majority of malignancies are going to be detected. If a patient doesn't meet this criteria, then generally that initial screening when the paraneoplastic syndrome is diagnosed would be considered sufficient and they don't require repeat screening. Now I want to talk about specific types of paraneoplastic syndromes and the different organ systems that they can affect. The first category I'm going to talk about is the paraneoplastic neurologic syndromes. And as we saw earlier, this is a very broad category of paraneoplastic syndromes. And It is important to realize that these are often diagnosed before a malignancy is detected, and they are generally rare, less than 1% of patients with cancer. But as we saw, they are relatively more common with small cell lung cancer, as well as lymphoma, myeloma, and thymoma. And this is really due to that presence of the onconeural antigens, and that causes the development of those tumor-directed antibodies. It is important to note as well that, generally treatment for the malignancy will improve the paraneoplastic syndrome, but with the neurologic syndromes, sometimes there has been permanent damage. So treatment of the malignancy will not necessarily improve all the symptoms related to neurologic syndromes. The onconeural antibodies as well are usually present in the serum, so CSF cultures or testing is often not required to detect the antibodies. The first example is limbic encephalitis, and this is a central nervous system paraneoplastic disorder. Actually, up to 70% of cases are not related to malignancy. There's a variety of causes that can cause encephalitis, including infectious or toxins or metabolic abnormalities as well. But you can see there is a strong association with small cell lung cancer as well as testicular cancer. And this generally presents with mood changes, hallucinations, seizures, and then you can see the associated antibodies there. Next, we have opsoclonus myoclonus, and this is an example of one of our high-risk phenotypes with a strong suspicion of a paraneoplastic syndrome, associated with breast and ovarian cancer, as well as small cell lung cancer and testicular cancer. And then this is also strongly associated with neuroblastoma and occurs in up to 2 to 3% of children with neuroblastoma. It's characterized by involuntary, chaotic, saccadic movements, and this means generally a rapid eye movement between two fixed points, but it can also occur in the trunk and limbs as well. Lambert-Eaton myasthenic syndrome is another one of our high-risk phenotypes, also associated with small cell lung cancer. And this is characterized by a progressive muscle weakness. It generally starts in the lower limbs and then moves to the upper limbs, also related to fatigue and weakness of the diaphragm and bulbar symptoms. And then up to 90% of patients have autonomic symptoms as well, including dry mouth, constipation, erectile dysfunction. And this is thought to be an autoimmune attack on the voltage-gated calcium channels. So this anti-VGCC antibody is found in the vast majority of cases. Cerebellar degeneration is another example of one of our central nervous system disorders. Again, we see an association with small cell lung cancer as well as a variety of other malignancies. This can present with prodromal symptoms such as dizziness or nausea and vomiting, and then this can lead to progressive ataxia, diplopia, and dysphagia, and then a variety of antibodies are implicated as well. As we saw at the beginning, neurologic syndromes are very prevalent with paraneoplastic syndromes, so these are other neurologic syndromes that can also occur with paraneoplastic syndromes. Myasthenia gravis can present as a result of a paraneoplastic syndrome, and there is a relatively strong association with thymoma. Myasthenia gravis is characterized by weakness of voluntary muscles, and this is weakness that's worse with exertion, so it's considered fatigable, and typically involves the ocular bulbar muscles around the eye as well as limbs, and then can be associated with weakness of the diaphragm as well. It is an autoimmune attack against the acetylcholine receptors at the neuromuscular junction. So associated antibodies are going to be the anti-acetylcholine receptor antibodies. For treatment, especially with thymomas, thymectomy can be considered. And then pyridostigmine is an important treatment. It helps prevent the degradation of acetylcholine by acetylcholinesterase, so it helps keep that supply of acetylcholine available at the neuromuscular junction. Autonomic neuropathy is another example of a paraneoplastic syndrome. is associated with small cell lung cancer as well as thymoma, and often has an insidious onset, but it broadly affects the parasympathetic and sympathetic nervous systems as well as the enteric system. A lot of those symptoms that we're going to see are going to be related to parasympathetic. So orthostatic hypotension as well as dry eyes and mouth can cause bowel and bladder dysfunction. And this is where we see one of our high-risk phenotypes, which is the GI pseudo-obstruction. And this occurs when there's no mechanical obstruction in the bowel, but it's related to a dysfunction of the myenteric plexus. There can also be alterations in pupil reaction time, and then our associated antibodies are listed there. To help combat especially the orthostasis, we can recommend increased water and salt intake and just helping to get that fluid volume back. Also for orthostasis, we can use fludrocortisone, midodrine, and caffeine. And then for the GI pseudoobstruction, neostigmine can be used. Sensory neuronopathy is another paraneoplastic syndrome, very strongly associated with lung cancer, so 70 to 80%. And also, again, an insidious onset over weeks to months. And this is generally accompanied by both sensory deficits as well as motor deficits. So there can be paresthesias and pain, generally involving the upper extremities first in this instance, and then can progress to ataxia. Deep tendon reflexes will also be decreased or absent. It is important to note with neuronopathy, though, that this can also be related to a Sjogren-type syndrome or a result of platinum-based chemotherapy leading to neuropathy, so may not always be a paraneoplastic syndrome. Finally, the last of our neurologic paraneoplastic syndromes that I'm covering is stiff person syndrome. And this is generally related to breast and small cell lung cancer, and it's characterized by painful muscle spasms, and these can be either spontaneous or triggered by some sort of stimuli. And they are related to concurrent activation of both antagonist and agonist muscles at the same time. Stiff person syndrome, when it's a paraneoplastic syndrome, often occurs in older patients and often involves the head or upper limbs. It is important to note with the anti-GAD antibody, which is the glutamic acid decarboxylase, this is an important feature of stiff person syndrome that's not related to paraneoplastic syndromes. So this can be an important distinction, and it is important to determine if the tumor is actually producing these anti-GAD antibodies as well to ensure that it is truly a paraneoplastic syndrome. Next, we're going to move on and talk about paraneoplastic endocrine syndromes, which include SIADH, hypercalcemia, Cushing syndrome, and hypoglycemia. So first off, talking about syndrome inappropriate anti-diuretic hormone, or SIADH. This is considered a hypoosmotic euvolemic hyponatremia, and the euvolemic part is very important in determining if this is actually an SIADH. So if a patient is euvolemic, it is important to really determine that their fluid status is balanced, and so we don't want to see the patient having any orthostasis or signs of peripheral edema. Their uric acid should be normal as well as their BUN with an elevated urine sodium. And SIADH with paraneoplastic syndrome is thought to be due to tumor production of anti-diuretic hormone, and this leads to an increase in free water absorption, causing essentially a dilutional hyponatremia. This occurs in strongly correlated with small cell lung cancer, so up to 10 to 45% of patients with small cell lung cancer. And the symptoms are really going to depend on both the severity of the hyponatremia as well as how rapidly it has developed. So for more mild cases, the patient may have headache or weakness or memory changes, but for more severe cases, and this generally occurs when the sodium is less than 125, there can be altered mental status as well as seizures, coma, and respiratory collapse. It's also important to consider the time frame with whether this is an acute hyponatremia, which means generally that it occurred within 48 hours in comparison to more chronic hyponatremia. And this will help determine how rapidly we can correct the sodium. So for acute hyponatremia, we can be a little more aggressive and increase sodium by 1 to 2 millimoles per hour with a maximum of 8 to 10 in 24 hours. In cases of chronic hyponatremia, however, the body has made adaptive changes already, especially within the brain, to prevent brain dehydration and intracellular swelling. So we actually want to be more cautious with these patients and only increase the sodium by 0.5 to 1 millimoles per hour. We also want to think about discontinuing any medication that may be contributing to SIADH. So this could include opioids or certain antidepressants. Also for our chemotherapy agents, cisplatin can cause it as well as vinca alkaloids. So important to discontinue those medications. Patients with SIADH will also often be placed on a fluid restriction, which is generally less than a liter of fluids per day. And then hypertonic saline with close monitoring so that we do not overcorrect the patient's sodium can be used as well to increase sodium levels. Other medications that aren't used as often include the vasopressin receptor antagonists, or the vaptins. And these are considered aquaretics, so they increase free water excretion, but they don't cause elimination of electrolytes. And then dimeclocycline can also be used as well. It affects how the kidneys process ADH, but it is also not commonly used. Hypercalcemia is another endocrine disorder that is relatively common occurrence with malignancy, so it does occur in up to 10% of patients with advanced cancer. And there are several different mechanisms for hypercalcemia of malignancy. Majority of cases are thought to be due to the secretion of parathyroid hormone-related protein from tumor cells, but there can also be direct osteolysis at the site of metastases that leads to increased serum calcium levels, which is about 20% of cases. As we saw with hyponatremia, the severity is really going to depend on the calcium level. And so severe hypercalcemia is generally going to be a calcium level greater than or equal to 14. And this is either an ionized calcium or a total calcium with a correction for the patient's albumin. So signs and symptoms of hypercalcemia include altered mental status, as well as ataxia, hypertonia, hypertension, nausea and vomiting, and a risk for renal failure as well. As we saw with hyponatremia, it's important to discontinue any offending medications, and these can include calcium supplements, of course, as well as any calcium-containing antacids or thiazide diuretics. Fluid administration is going to be key for hypercalcemia, helps to increase the filtration rate and help the kidneys eliminate more of the calcium. Loop diuretics can also be used, but should only be used after the patient has received adequate IV fluid resuscitation. And then our IV bisphosphonates are going to help inhibit the osteoclastic activity of bone resorption. And so our two go-tos are going to be zoledronate and pamindronate. And then corticosteroids can be used. Generally, they're used more for their anti-tumor effect directly with lymphoma or myeloma, but they can be used in this instance. And then calcitonin also can be used to help increase the renal excretion of calcium. However, there is a risk for tachyphylaxis with calcitonin, so it cannot be used long-term. Cushing syndrome with paraneoplastic syndrome is unique in that it is often present before the cancer diagnosis is made in comparison to some of the other endocrine disorders. And it's thought to be due to increased tumor secretion of the adrenocorticotropic hormone, or ACTH, or corticotropin releasing factor. So this directly causes increased cortisol secretion from the adrenal glands. So typically, baseline cortisol is going to be greater than 20. Signs and symptoms include hypertension, hypokalemia, muscle weakness, edema, and weight gain. And one of the unique factors with Cushing syndrome as a paraneoplastic syndrome is that it's generally unresponsive to the dexamethasone suppression test. And this involves giving dexamethasone on a scheduled basis and then monitoring the patient's cortisol level. And the suppression test is considered positive if there's a greater than or equal to 50% decrease in cortisol levels. But again, with paraneoplastic syndromes, generally this may not happen. In terms of treatment, there are several options to help inhibit steroid synthesis, including ketoconazole and etomidate. Also, octreotide can help to block the release of ACTH. And then symptom management, particularly with antihypertensives and then diuretics to help eliminate the fluid retention. If this management is not effective, however, the patient may require surgical removal of the adrenal glands. Hypoglycemia can be a more rare cause of a paraneoplastic syndrome, and this is related to either insulin secretion from an islet cell tumor in the pancreas, or can be related to a tumor outside the pancreas. Generally, if it's an extrapancreatic tumor, it's going to be more common in our elderly patients with more advanced cancer, and this can be associated with very profound hypoglycemia, so blood sugar can get as low as 20. For our treatment options for hypoglycemia, we have our emergent options, including oral and parenteral dextrose and glucagon. Corticosteroids can be used as well as growth hormone for their hyperglycemic effects. And then diazoxide can be used to help decrease or inhibit insulin secretion from the pancreatic beta cells. Octreotide, as we talked about with Cushing syndrome, can be used due to its decrease of ACTH release, but important to know with octreotide, it can actually worsen hypoglycemia, so generally a test dose is recommended before it is given. Finally, I want to talk about the paraneoplastic dermatologic syndromes, and fortunately, these actually more commonly occur without an association with cancer, but if they are related to a paraneoplastic syndrome, they are generally harder to treat and more unresponsive. These include dermatomyositis, as well as hypertrophic osteoarthropathy, Sweet syndrome, and paraneoplastic pemphigus. Dermatomyositis is related to paraneoplastic syndromes in 10 to 25% of cases, and you can see it's related to a variety of cancers, including ovarian, prostate, breast, lung, colorectal, and non-Hodgkin lymphoma. And as you can see in the picture, there's this kind of unique heliotrope or purplish rash, and this can develop as an edematous rash on the upper eyelids. There can also be scaly papules on the bony surfaces, and sometimes with the scaly papules, this can be mistaken or mimic psoriasis. And then for laboratory findings, there can be elevated creatine kinase as well as liver function tests and LDH. Generally, if it is a paraneoplastic syndrome, there's often a higher elevation in CK levels, and CK levels can actually be trended to monitor response to treatment. And then often patients will have more systemic symptoms if it is related to a paraneoplastic syndrome. Next, we have hypertrophic osteoarthropathy, and in contrast to dermatomyositis, this has a strong correlation with paraneoplastic syndromes, so up to 90% of these cases are paraneoplastic in origin. And for associated malignancies, these include intrathoracic tumors as well as those with metastases to lung or bone, nasopharyngeal carcinoma, and rhabdomyosarcoma. It's characterized by this development of new bone on the phalangeal shafts. So as you can see in the pictures, it leads to hands that look like clubbing, especially that we would see with patients with COPD or a smoking history. But in this instance, it's due to new bone deposition. Symptoms include synovial effusions in the joints, as well as pain and swelling along the bones and joints. And then on imaging, there's going to be high levels of reaction, periosteal reaction along the long bones. For treatment of this condition, NSAIDs and opioids are going to be recommended for pain management as well as bisphosphonates and then localized radiation as well. Sweet syndrome is another syndrome related to paraneoplastic syndrome. It's officially known as acute febrile neutrophilic dermatosis, and this is associated with leukemias, especially AML, also non-Hodgkin lymphoma, myelodysplastic syndromes, GI, multiple myeloma, testicular melanoma, and gynecologic. And it's characterized by the development of these erythematous, very tender nodules, papules, plaques, or pustules. And as we see in the picture here, typically it's going to involve the upper trunk, can also involve the extremities or the face. There is generally more systemic symptoms involved, including elevated neutrophils, fever, and generalized malaise. And for treatment, topical steroids can be considered, as well as direct steroid injection to the lesions with triamcinolone, and then systemic steroids with methylprednisolone or prednisolone. Finally, for our dermatologic conditions, we have paraneoplastic pemphigus, and this is related especially to our B-cell lymphoproliferative disorders, including non-Hodgkin lymphoma, CLL, thymoma, and Castleman disease, which is characterized by a lymph node hyperplasia. As you can see in the picture, this involves blistering as well as development of severe erosions in the trunk, on the trunk, soles, and palms, and can also involve stomatitis. It's thought to be due to antibodies with tumor antigens that have cross-reactivity to epidermal proteins. And then generally a skin biopsy will show necrosis of keratinocytes. This is a very serious condition and can be associated with a greatly increased risk for infection and morbidity, as well as mortality. Last, I want to talk about our paraneoplastic hematologic syndromes, and these actually are often asymptomatic and are often going to be diagnosed after cancer has been found and are more commonly associated with advanced cancer. So these include eosinophilia, granulocytosis, thrombocytosis, and pure red cell aplasia. First off, we have eosinophilia, and this is thought to be related to tumor production of eosinophil growth factors, including interleukin-5, interleukin-3, interleukin-2, and our colony-stimulating factors. Can occur with a variety of malignancies such as lymphomas, CML, ALL, lung, thyroid, gynecologic. As I mentioned, these patients are often asymptomatic, but they may present with dyspnea and wheezing. Generally, our eosinophil counts are going to be over 500. It is important to note as well that eosinophilia can be due to a variety of non-paraneoplastic causes, including allergic reactions, parasitic infections, and then collagen vascular diseases. But generally, our treatment is going to be use of inhaled corticosteroids. Next, we have granulocytosis. As we saw with eosinophilia, often these patients are asymptomatic, and really the mechanism for granulocytosis is not well understood, but it's thought that certain tumors release colony-stimulating factors that can contribute to granulocytosis, associated with a wide variety of malignancies, including GI, lung, Hodgkin lymphoma, and sarcoma. And generally, the granulocyte count is going to be above 8,000. But it is interesting to note that even with this high granulocyte count, since they are mature neutrophils, there's a big distinction between granulocytes and leukemic blast cells. Leukemic blast cells, even at counts less than 20,000, can cause severe vaso-occlusion and hyperviscosity. But granulocytes really can get up to counts up to 250,000 before we would worry about concern for vaso-occlusion. So in general, there's no treatment indicated. Thrombocytosis, which is generally defined as a platelet count above 400,000, carries a relatively strong association with malignancy, so up to 35% of patients with thrombocytosis have an underlying malignancy, which can include GI, lung, breast, lymphoma, prostate, and glioblastoma. Again, often these patients are asymptomatic, but it's interesting to note that in terms of determining if it is due to a paraneoplastic syndrome, elevations in IL-6 can help to determine if it is, in fact, paraneoplastic. There's also a new mutation, the JAK3 mutation, that has been associated with development of thrombocytosis. But it is important to note that there are other causes of thrombocytosis, not paraneoplastic. This can include essential thrombocythemia, polycythemia vera, as well as acute and chronic leukemia. And then there can also be reactive thrombocytosis, and this can occur secondary to surgery or splenectomy. So in general, no specific treatment is indicated. Finally, we have pure red cell aplasia, and this is commonly associated with thymoma. And for paraneoplastic syndrome, it's thought to be due to this incomplete eradication of autoreactive T cells from the cancerous thymic tissue, and this causes an autoimmune attack on all of the red cell precursors. So patients are often symptomatic with this condition. So they present with profound anemia, hematocrit can be less than 20%, as well as dyspnea, pallor, fatigue, and syncope. And with bone marrow studies, they will be found to have generally no or nearly absent erythroid precursors, but their platelets and white blood cell counts will be within the normal range. So for treatment, emergent treatment, we would require blood transfusion. Also, the anti-thymocyte globulin can be used to counteract that autoimmune component related to thymoma. And then immunosuppressive agents can be used, such as prednisone or cyclosporin. However, these should be used cautiously because immunosuppression has been associated with an increased risk for malignant transformation, as well as use of erythropoietin stimulating agents such as erythropoietin or darbepoetin. They've also been linked with an increased risk for development of pure red cell aplasia. Other treatment options include plasma exchange and splenectomy. All right, so finally I want to come back to our case study. Again, this is the 27-year-old female who presented to the ER with severely altered mental status and agitation. So again, her imaging was negative, her lumbar puncture was negative, lab results were within normal limits. So she underwent a transvaginal ultrasound, which revealed a hyperechoic lesion in her left ovary that you can see on the left there. She underwent surgery, had a laparoscopic resection, and the pathology showed a mature teratoma. So at this point, the patient was diagnosed with anti-NMDAR encephalitis, as we saw earlier in our presentation. So she underwent standard immunotherapy treatment with plasmapheresis, IV immune globulin, and then unfortunately she also developed refractory seizures and required multiple anti-epileptics, including a pentobarbital-induced coma for up to 48 hours. But fortunately, she did make a profound recovery, and after a very lengthy 6-week hospital stay, she was able to be discharged to an acute rehab facility. And she has made a full recovery and has not had any relapse of her encephalitis in 2 years. But I just think it's a very interesting case study, again highlighting that paraneoplastic syndromes may develop before the patient is aware of an underlying malignancy. All right, so moving on to summary. Paraneoplastic syndromes were first recognized over 100 years ago, and they were recognized in that patients presented with symptoms that were not directly related to either tumor invasion or metastases or underlying metabolic abnormalities or coagulopathies. And in general, they're thought to be due to an ectopic tumor secretion of a variety of substances, including peptides, cytokines, and hormones. And this essentially leads to an immune cross-reactivity, where there's an autoimmune attack against the tumor that then spills over into normal host tissue. One of the predominant antibodies is the onconeural antibody, and this was recently updated in 2019 to be reworded to include high-risk and intermediate-risk antibodies to have a more broad definition and then also express the relative association of these antibodies with development of malignancy. Some of the most common malignancies associated with paraneoplastic syndromes include small cell lung cancer, breast cancer, ovarian cancer, Hodgkin lymphoma, and thymoma. And then also for children, neuroblastoma is a common malignancy. As we talked about, neurologic paraneoplastic syndromes are probably the broadest category, but paraneoplastic syndromes can also occur with endocrine, dermatologic, and hematologic systems. And then, as we especially saw with our case presentation, these patients may present with a paraneoplastic syndrome before they know they have a malignancy. So very important, if a paraneoplastic syndrome is suspected, to have the patient undergo a thorough screening, and depending on their risk profile, they may require repeat screening for up to 2 years to help detect any occult malignancy. First and foremost, if there is a tumor detected, it is important to treat that underlying tumor to then treat the paraneoplastic syndrome. And then often patients do require immunotherapy, which can include IV corticosteroids, IV immune globulin, and plasmapheresis. And then often patients require maintenance therapy with other immunosuppressives, such as cyclophosphamide, rituximab, azathioprine, or mycophenolate. Thank you so much for listening to my presentation on paraneoplastic syndromes.